I've just been thinking of all the reasons I would fall in love. I don't know why, but here's what I can say. I can say. Do I love you? Oh my, do I? Honey, indeed I do. Baby, you know it's true.
I'd like to kick off the session now. It looks like we have a number of folks that have joined. So hi, I'm Rob France, and I've been, as you know, coordinating the Leadership Academy sessions. This is our final session. We've got a couple of sessions that we weren't able to get to here, and we're going to be not rescheduling, but we're going to be scheduling some additional sessions that I'm trying to coordinate. One for VP of Program, I just kind of mentioned. This being the executive session, though, we'll get into some of the combined content that we normally have. So we have John Santora online. Thank you, John, for being here, Jeff Porter, and myself. So we can cover the President, Secretary, and Treasurer tracks when we get that far. But it was suggested to me actually a while ago that I should probably reach out and contact Jason Lee here, and thank you for being here, Jason, to help and to talk to us about a topic that we're all concerned about. Now, I want to say a couple of things here, and you'll notice that Steve Kirsch is on the line, and I'm very happy that you were able to make it, Steve. Thank you for being here. We're going to talk about, and why I felt that this would be important is to talk about COVID and statistics and the content that Jason's going to introduce here to us. And we want to use this information. I think this is helpful for us to figure out what we're doing in our chapters as we get back together and we're singing together. What do we do? What do we not do? Those sorts of things. How do we consider what we should do? So we're going to kick into that. And this is really meant for chapter support, not really for district level or international level or society level. I know questions might come up that you might have about upcoming events. So I'm going to deflect those to Steve. Steve, do you want to say a few words, though, about where we are with that, so we can sort of answer some of maybe things that are on people's minds first?
Yeah, so I don't want to jump on anything Jason might talk about later, because he's been such a huge help, along with George Korch from Patapsco, in helping us to find the path we're going to follow for our spring conventions. But everybody saw the email that went out this past week talking about our protocol set up for the spring convention. It is to me, it's a very strict protocol in that we are doing everything we can to maintain the safety of all of our members who happen to attend the convention. We're trying to mitigate as much of the risk as possible. Jason, I'm sure, will talk about a lot of that in a bit, but we're doing everything we can to make sure that our members stay safe. I'll use the quote from our district president, Brian Schreiner, and say that we don't like any of this, and it absolutely sucks. We would prefer to open everything up and make it so that we can all be together, unmasked, and enjoying our hobby the way we know we and love. But the situation right now, and especially given our demographic, we need to make sure that we do everything we can to keep everybody safe. So I'll invite questions probably after the next presentation. But yeah, that's where we are right now. So I want to thank everybody for, first off, attending. Being part of these training sessions is great, and I think it helps everybody. And it's a way to socialize, even though it's Zoom. It's a way to socialize and and share thoughts. So thanks, everybody.
Cool. Thank you. All right. And with that, I'd like to pass the baton over to Jason. Jason, if you would say a few words about yourself, part of your bio that you said. I'm not going to read it for you. You can say it much better than I can.
Fine. That all sounds good. Well, good evening, everybody. It's great to see you all, albeit virtually. My name is Jason Lee. I'm a biostatistician at the Johns Hopkins University Applied Physics Laboratory, or JHU APL. I am also a section leader and the COVID committee chair for the Alexandria Harmonizers, a chorus that you may have heard of before, that sits in the Mid-Atlantic district here. So yeah, my background is in biostatistics, and essentially what that means is I'm a statistician that has a public health bent. So I almost all of my work deals with health outcomes and health disparities for populations. I do a lot of work with Johns Hopkins Hospital, for instance, looking into things like whether or not somebody is at risk for complications or at risk for a certain type of disease. And then I also do some population health work as well, looking at population health outcomes for things like musculoskeletal injuries in the military, for instance, who might be at most risk for those sorts of things. In 2020, at the outset of this pandemic, there was essentially an all call from my lab, from JHU APL, to try and help out as much as we can, with the COVID situation. And so, folks like myself, statisticians and epidemiologists and mathematical and statistical modelers, were essentially called to the front lines for places like the White House and the CDC and places internationally as well, which is where I did a ton of my work with the United Nations and the Office for the Coordination of Humanitarian Affairs out there. So much of my work in 2020 involved developing a model to project COVID cases in far-flung places that don't have a ton of data infrastructure. So if you think of a place like Afghanistan or a place like the Democratic Republic of the Congo, these are places that don't have a ton of data infrastructure for us to be able to know kind of what the situation is on the ground, with respect to a disease that is coming through the population. And so, that was our task, to try and find a way to model where COVID might strike and how it might strike in some of these countries, whether or not there would be waves of COVID as we've seen in some of these places. So that's a little bit about me. So with that, I'll get into my presentation that I've got for the evening. All right, so I'm here to talk about risk assessment and using the available data, the available models, and the available simulations to properly assess risk. So this will be, I think, at least partially a very mathematical and statistical talk. And I will do my best to put on my professor hat and break down as much of this into layman's terms as possible. And then we'll move from that to the kind of the practicality of things as well. And I'll shift hats from that stat hat over to the COVID committee chair hat and talk a little bit about what we in Alexandria have done to think about risk assessment and what that means for us as a chapter. So first things first, I'll talk about the current situation, where we stand in terms of cases, deaths, all of that, what we know about COVID and its transmission. Then we'll talk about translating what we know into parameters to build out a model. And we'll go into a little bit of math on disease modeling and simulation and what that might look like. And then we'll get to risk assessment and considerations. And we'll talk, I think, at length about some of that. And then also, I'll display a number of resources that you can use for your individual chapters to help assess that risk or to help kind of understand that math a little bit better. Okay, so first and foremost, where do we stand? This is a timeline of the entirety of COVID. I've pulled this from the New York Times coronavirus tracker, which is just one of multiple coronavirus trackers that I use. The reason that this graph is up and not one from Johns Hopkins University or not one from the CDC is because it fits on my screen the best. All of these trackers that you might see, whether it's the JHU coronavirus map, the New York Times coronavirus map, the CDC map, all of these use data that are coming from very similar sources. They're typically sourcing data from the public health departments or the hospitals that are associated with individual counties or individual states. So this is just looking at the US, and so this is an aggregation of all US cases. The Johns Hopkins map does a better job of looking at things globally, but the Times and CDC are obviously looking at the US and its territories. And so you can see, we're in this wave here. If we look recently, this is Omicron right here. Number of cases is way up, way over our previous highs, which happened back in January of 2021, as well as the Delta wave, which is what you can see here around August and September, again, nationally. In terms of deaths and hospitalizations, you can see the hospitalizations are past their peak where we saw in both January of 2021, as well as the Delta peak, which doesn't quite get all the way up to where we were last winter. But you can see the difference here between how high this number is in terms of hospitalizations and how high this number is here in terms of cases. This likely speaks to two things, and these two things confound with one another. One is, probably heard about this, the amount of vaccination that is happening in the population is very high now. It was not high, it was virtually zero here in December and January of 2021. And now we've essentially got 60 to 70% of the population vaccinated and about 80% of all adults vaccinated as well. So, mostly the unvaccinated at this point are mostly kids and then immunocompromised and about 10 to 20% of adults. So that's part of the reason why we see this disparity here in terms of cases against hospitalizations and deaths. The other reason that you might see this, you might have heard about this before as well, but the reduced severity of Omicron compared to previous waves. It is believed that Omicron is slightly less severe than either the Delta wave that came through, the Alpha wave that came through, or even this original lineage back in December of 2021. And you see that both in hospitalizations and in deaths. Notice that the death numbers here are not quite as high. The death numbers currently not quite as high. And you'll see that they're kind of rising here, right? And cases are dropping, hospitalizations are dropping. The reason behind that is because hospitalizations and deaths are what we call lagging indicators of disease. That essentially means that they lag behind when the infection happens, which makes sense when you think about the course of disease, right? You're going to get sick, you're going to have complications from that sickness, whether it's fever or cough, or you can't get any oxygen into your system for 10 days at a time. And eventually you go to the hospital, and if your case is severe enough, eventually you may die from that. And that course takes about 3 weeks to progress all the way through. So you'll notice the hospitalization numbers are still near peak, that they're starting to come down. The case numbers have been coming down for a little while now. Tests over here, you'll notice tests are up as well and starting to go down. Tests are probably a good leading indicator. So if people are sick or if people have a known exposure, they may go and get tested. That test may result in a case as a result. So tests your leading indicator, so you can kind of get a sense of what might be going on in the population by looking at tests, and then cases as the actual indicator themselves, and then hospitalizations and deaths as a lagging indicator. So if there's data that you're looking at to determine, okay, where are we now in my region, or where are we now as a nation, tests and cases are really kind of the good things to look at. Hospitalizations and deaths, less so. Here's a graphical or a mapical look of where we stand. Again, I'm pulling this from the New York Times coronavirus tracker. Legend down here at the bottom right. So purple, the deep purple is bad. The closer that we get to this light yellow color, the better off we are. And so you'll see here, nobody in the mid-Atlantic region, which I've kind of zoomed in on, is light yellow. Nobody is out of this and celebrating, the end of the Omicron wave, right? Cases in Maryland and in DC and in the Northern Virginia region are coming down, right? That's that orange color. You can see it out here in kind of the Cleveland area as well. Things are starting to abate, but largely, out in Pennsylvania and some of these areas in New Jersey and Delaware, out on the eastern shore of Maryland, and for much of Virginia, we're still at or near peak in terms of the amount of cases that are happening in the region. So we're probably a little bit behind these numbers if I were to just scroll between these two, right? Seems like DC, Maryland, right, where I live, we're kind of on the leading edge of these cases. The case rate in our area has been dropping for a little while now, probably a little prior to this US peak. And other places that are out here in kind of the the less urban regions out here in kind of Harrisburg, Pittsburgh, some of the Philly suburbs as well, and, central Virginia, they're kind of tracking right along with the US cases. So how does COVID spread? Let's talk about this for just a little bit. This is kind of a way to think about mathematical modeling. COVID spreads through exponential growth. This graph here at the bottom kind of illustrates it quite well, right? If I have one case, that one case is going to spread to multiple other cases. And then those multiple other cases are going to spread to multiple other cases, and so on and so forth. And so you have this exponential figure that kind of looks like what we see here, right? If you recall, at the beginning of the pandemic, March of 2020, right, we had very little cases, and then we had a few, kind of had a trickle in the US, and then all of a sudden, bam, it was a lot of cases very quickly, right? We kind of see that in the waves that we've had ever since as well, right? Cases will be down, then all of a sudden there's kind of a little bit of an uptick, a little bit more of an uptick, and then all of a sudden it's severe, right? The reason behind that is this concept of exponential growth, right? If the number of COVID cases is doubling every single time there is a kind of a regeneration, we go from 1 case to 2 to 4 to 8 to 16 to 32 very quickly. And so as a result, you get that kind of hockey stick curve that you might see here. So we call that exponential growth rate R naught. This is essentially the rate that epidemiologists and biostatisticians like myself use to determine the severity of how quickly something might spread. And so, this is the average number of people infected by one person with a disease. So if we're going from 1 to 2 to 4, that R naught number would be 2, because one person infects 2 people, those 2 people then infect 2 other people, and so on and so forth. So it's the exponential number of how quickly a virus may spread. The initial lineage of COVID was thought to have an R naught of about 2.5. So that is, for every one person that catches COVID, on average, they would spread that disease to 2.5 other people. That doesn't mean that is a uniform number. That is an average number. Obviously, we've heard of things like super spreader events, where one person could spread to a lot of people. And then there are other people that might not spread to anybody else at all. Think of somebody that's very conservative, or somebody that realizes that they've had an exposure and may isolate themselves, or may just kind of ride it out in the courtesy of their own home, right? They may not pass along the disease to anybody, or they may only pass it along to those folks that are within their household. So this is just an average number. For Omicron, this number is a little higher. We think that it's roughly twice, or actually a little more than twice as transmissible as the original strain of SARS-CoV-2 that was going around in 2020. And so that R naught number is about 6.25. We think it's about 2.5 times as transmissible as the original strain. Just for comparison's sake, between Omicron and Delta, which was the previous wave, we thought that Delta was about twice as transmissible as the original lineage, so an R naught there of about 5. So one person could spread to about 5 people on average. So, Omicron, very transmissible here. If we think about the history of disease, this is a very transmissible virus, about as transmissible as measles. So what can we do to reduce this R naught figure? Well, we have non-pharmaceutical interventions. These are interventions that help reduce viral spread. And they're all about, remember this term, flattening the curve, right? Reducing that RT, which is not R naught, but it's a very close relative, so that it's less than 1. So what is RT, you might ask? RT is essentially the reproduction figure right now. What is happening in time? R naught would be the case where it's perfect for the virus, right? Everybody is susceptible to virus, and so anybody can be exposed, anybody can become infected. In that case, Omicron is very transmissible. We can reduce how transmissible Omicron or COVID as a whole might be through these non-pharmaceutical interventions. These are things like mask wearing, social distancing, hand washing, or community-based measures. If you recall back in 2020 and 2021, a lot of travel restrictions or school and restaurant and work closures, crowd control and restrictions, right? Kind of putting limits on the number of people that might be indoors in a certain place. Now you might ask, right? NPI, non-pharmaceutical interventions. That implies that there's a different type of intervention, and there is. It's called a pharmaceutical intervention, which, as we might be aware of, is a vaccine, right? So, vaccine, pharmaceutical intervention, obviously, it does the same thing. It's just pharmaceutical in nature. Whereas these things are things that do not require a jab, do not require the side effects that come with a jab. So these are all things that are at our disposal that we can use to help reduce this figure so that we end up in a situation where R is less than 1, right? So that on average, if a person is infected with the virus, they're passing it on to less than 1 person. If R is greater than 1, we have a growing pandemic. If R is less than 1, we have a declining pandemic. So if I were to go back again, all the way back to this slide, right? When the cases are rising, we have a growing pandemic. Our T is greater than 1. When we get over the hump and we get to this side of the hump, now we have a declining pandemic. R is now less than 1. And the R tends to decline over time. Why is that? Because more people have gotten infected, which means there are less people that are susceptible. So the less susceptible people there are, the fewer people that the virus can go after. And as a result, you end up with an eventually declining pandemic. I'm going to get out of the slides here and just skip back to where we were. So we've talked about cases, we've talked about hospitalizations and deaths, we've talked about, kind of how the pandemic continues and how it moves along. This is an important point too. How do we count cases, right? How do we know that the number of cases that we have is the right amount, or that we're not undercounting or overcounting or something like that? We do that using testing, and testing can accurately assess cases, including asymptomatic cases, and then identify this RT, the rate of viral spread in the population. So in an ideal situation, you want to test enough in the community so that 5% of tests are positive. This is that test positivity rate that you might have heard about before. And if that number is below or at 5%, the general thinking among public health folks is that you're getting a good sense of the number of cases in the population. If that number is greater than 5%, there's a good chance that you're not catching the full amount of virus that's in a population. So this test positivity rate correlates to what's called ascertainment bias, which is the amount of cases or infections that are caught by testing. Now, no amount of testing is going to be a perfect amount of testing, because in a public health situation, you're not going to be able to test everybody, right? In a country as vast as we have, and in counties or in states as vast as we have them, you're simply not going to be able to test everybody and understand where the virus is. So only a certain number of people are getting tested, and within that, you can kind of then assess how much of the virus you're catching through the positivity rate. So the ascertainment bias is thought to be a good kind of general number as to where we stand, but that number varies with the test positivity rate. So there's a floor to it, right? If we have no test positivity in the environment, that doesn't mean that there's no virus in the environment. It probably means there's some virus or quite a bit of virus still circulating, but it's all in people that are asymptomatic or don't have a known exposure. So because of that, there's a floor on the ascertainment bias. And so we think that at bare minimum, or at bare maximum, I should say, we're capturing a third of all infections. And that number can only be lower than that. So at our best, we're capturing a third of all infections. At our worst, when test positivity rate is through the roof, we're not capturing that number. We might be capturing 15%, or maybe even 10% of the number of cases that are truly out in the wild. Just a quick note on testing types. We've got two different types of testing. They kind of do different things, right? There's the Anagen test, which is also known as the rapid test. It's looking for a protein that's part of the coronavirus. It's quick to perform and obtain results. It's inexpensive. These are the things like the Abbott Binx Now. It's good at identifying persons that have a ton of viral load in their throat or in their nose. However, it is less accurate. It has a high false negative rate. So we'll get into what a false positive is and what a false negative is in just a second. We also have a PCR test. This is the test that comes back from a lab in at least 4 hours. And what is happening with that test is you get swabbed in your nose, and that test goes to a lab. They allow any bacteria that's on that swab to replicate and replicate and replicate and replicate a number of times. At the end of that number of cycles, you get a sense as to whether or not somebody has an amount of COVID in their system that would be associated with positivity. This kind of test is more accurate. It's got a low false negative rate, and it can detect even a small amount of genetic material because it's doing that replication cycle over and over and over and over again. However, it can take longer to process, right? At its quickest, it takes 4 hours. Typically, it takes about 2 days to process. And it also has a higher false positive rate. So what's a false positive? What's a false negative? How are they important here? A false positive means that I might get a test and that test comes back positive, when in actuality, I am negative for the test. So the test says that I have COVID, but I don't have COVID. That's a false positive. A false negative is the opposite. The test says I'm negative, I don't have any test, or I don't have any COVID, when in actuality I do. One of these is worse than the other, right? A false positive, while it might be a hassle and while it might be unfortunate, a false positive is safer than a false negative when you might have a false sense of security, and then in actuality you have persons that are testing positive and then can spread the virus to other people. So let's talk just a little bit about modeling and what this means. I've kind of thrown out some of these terms already. I've thrown out the term susceptible. I've thrown out the term infected. I've thrown out are not before. So when we look at models of what the virus might be doing, this is the general model that is followed. It's called an SEIR model. And its origins actually go back 100 years to the last pandemic that we had back in 1918 with influenza. That huge pandemic that spread throughout the world. This model was developed at that time. And it is thought that this model is generally pretty good and generally pretty accurate. And so this is the base model that a lot of modelers use when they're looking at what the rate of infection might be, what the number of cases might be down the line. So you start with a susceptible population. You can think of all of these boxes as kind of individual parts of the population. And you can think of everybody as being in one of these boxes. You're either susceptible to the virus, you've been exposed, you are infected, which means that you actually have a case, you're recovered from that case, or as is unfortunate, you might die from that case. And so there are a number of things that go into this model, right? There's the basic reproduction number, which we've talked about, right? That reproduction number is actually a fraction. It's a fraction of these two Greek letters, beta and lambda. And the transmission rate is beta. That's how often a virus might transmit. And then there's the infectious period, 1 over, this is actually a gamma. I screwed up my, my Greek lettering. So 1 over gamma, that's the infectious period, how long it might take for somebody to become exposed or to become infected. So that's that figure. We also have the case fatality ratio, which is 1 minus F. Probability of recovery is F. So somebody gets infected, they have a probability of recovery F, and that happens over a period of time gamma. And then a latent period after exposure, that is 1 over sigma. So it takes time for somebody to go from exposed to infected. That's the sigma right here. How long does it take for somebody to go from exposed to infected? If they go that route at all, it's possible for somebody to be exposed and not end up being infected. So, and if that's the case, they would cycle back into the susceptible category. So again, we can think of everybody as in one of these 5 bins. Vaccination, by the way, takes everybody from susceptible, moves them over into recovered. And when we've heard about things like waning immunity, that's taking people from this recovered population and slowly leaching them back into the susceptible population. So this is the base model, but yeah, there are additional things that get added on, and how these things get added on, or how we model, is through differential equations. If you remember back in high school or back in college, you went through the calculus series perhaps, and you thought, I'm never going to use that again. Well, friends, you're wrong. Here we are. So this model essentially works through differential equations, and it is the derivative of this over time. How does the susceptible population change over time? Well, it's a function of who is infected, and it's a function of, at least to some extent, who is exposed. So, if you're infected, if you've got an amount of infected people in the population, they're going to transmit the virus to an amount of susceptible people. And so the susceptible population, or how people move from susceptible to exposed, depends on how many are infected. And how many are infected can change over time depending on who has been exposed, right? And then how quickly the infected move to the recovery bin, right? So all of these things kind of change over time. And so the differential equations model kind of helps us to utilize these things to then say, okay, this amount of infected people are here at this point in time. They will transmit over this period of time to this amount of people, and those people then move, right? We have then what's called a Markov chain model, or a time-based model here. And so we can run this model then through multiple time steps to get a sense of what things might look like in the future. So when all of that is done, we have what's called an ensemble. And that is an aggregation of many people doing a lot of this work and doing a lot of the hard math to get out their models. We have a saying in statistical practice: all models are wrong, some are useful. And that could not be proven more correctly than in this pandemic. We have seen models perform well, we have seen models not perform well. And so it is on us as public health professionals and as statisticians and epidemiologists to convey that uncertainty to the general public. And so one way that we can kind of reduce uncertainty is through this practice of ensembling, right? I have a model, I've thrown some assumptions in, and I've thrown some methods in that are based in scientific practice, right? Those assumptions might be what the case fatality rate is, or what the infectious period is, or what human nature might be 4 weeks from now. In fact, that's a big part of a lot of models and how they forecast. They think about, all right, what is the population going to do 4 weeks from now, or 8 weeks from now, or 12 weeks from now? That's a hard thing to predict. And so as a result, you have a ton of assumptions as to what the population might do, or how the population might react to case counts being what they are. And so as a result, you have different assumptions, you end up with an ensemble. So I'm going to pause my slideshow here, and I'm going to show you one place where you can look at an ensemble. So this is, hopefully you all can still see this. This is the COVID-19 Forecast Hub. On the left here, I've got a number of buttons so I can look at cases or deaths or hospitalizations. I'm looking at cases right now. And I have location. I can get down to the state level. All of the models that you're about to see do their modeling not only at the national level, but also at the state level. Some of these models even go down to the county level. But as you might imagine, county level data can be quite hard to come by, or can be quite inaccurate or filled with holes. So typically people model at the state level. And then there's this thing called interval. If I have it set at 0%, but what happens if I put it at like 50%? I get these bars over here, the shaded area. That's what's called a confidence interval. So if I have this interval at 0%, these are point estimates, as you see on the right, for a number of models, right? UVA Ensemble, USC. There's the JHU APL Bucky model, which I was fortunate to help develop back in 2020. Got this guy Pagano and IHME, right? These are just some models that are out in the universe. There are other models down here on the left that you can select from. So if I were to select this one, for instance, that does not show up all that well. Let me try and find one that shows up a little better. There's one, right? You can see it populates on the right with its projection. If I go down to this one, right, that one populates on the right with its projection. And quite a few of these overlap. That one seems to think that we're not at peak and that we're going to go up, right? So I have chosen, just to showcase here, a set of 5 models that I believe have performed well in the past. You'll notice here this caveat at the top, right? Most forecasts have failed to reliably predict rapid changes in the trends of reported cases and hospitalizations. Due to this limitation, they should not be relied upon for decisions about the possibility or timing of rapid changes in trends. So you might be saying to yourself, well, we have these models and people are working hard on them. Why even use them, right? Well, they perform well when RT is stable, when we have a wave that is ongoing. Where they don't perform well is in places like this. If I were to scan, if I were to go back, I'm just going to toggle to the left here, right? You can see the models, the individual models, they're doing okay, right? They're generally where that gray line is or in the vicinity, right? Where they don't do well is when there's a rapidly increasing outbreak. And so here is where I would encourage you to not look at models, is when there's an outbreak, right? You can see Omicron took off here. The models weren't expecting this. Why weren't the models expecting this? Because in the previous data, looking back at the 4 weeks prior, it's a little hard to see. So, just kind of look above where my mouse is pointing here, right? But you can see the rate of data, or the amount of cases that's coming in, is fairly stable. And so the models are thinking, all right, the number of recovered people is high, the number of susceptible people is low, the number of infected people is relatively low. So yeah, there might be a bit of a winter wave that's upcoming, but we don't expect it to be that bad. Well, then Omicron happens and it changes the game. How does it change the game? It takes all of those recovered people and it says, now we have immune escape. Now half of the people that are recovered are no longer recovered, right? And the models are not keen to that, right? They don't know that, because models are not all knowing, right? All models are wrong, some are useful. So where they are useful is in situations like this, where you might have a rapidly increasing outbreak and you want to know, all right, how bad is it going to get? What does it look like? When might the peak be, right? And you can see some of these models do it better than others. And some of the models that I'm not showcasing might do it better than others. So I would encourage you to play with this website. Look at some of the models. Look at their individual performance. Determine which ones you might like or you might not like, right? The ensemble, if you're lazy and you just want to go, all right, Jason, I don't care about previous performance. I just want to know what the average of the models is, right? You can get that. COVID Hub Ensemble, that first thing, right? And that's actually the default. If I were to reload this page, it'll just show up with just the ensemble. And then I'm showing individual models that I think perform decent to good. So you can see here, right, kind of looking at the current situation, this is as far forward as models go. They're predicting weekly cases in the US as of January 22, which is last Saturday. And you can see it's generally a downward trend from all of these models. Some of them bring it down steeper than others. And if I were to go to, let's just use the District of Columbia as an example, right? You can see we're over the peak and things, according to these models, probably going to get really good for us here pretty soon, right? If I were to go to, say, Pennsylvania, there's Pennsylvania, right? You can see Pennsylvania is broadly over the peak and things are going to get better in roughly 4 weeks, but the degree at which they get better kind of depends on which model you might look at. Some of these are better than others. So again, just one tool in your toolbox for you to use. Now you might notice again here, these models only go out 4 weeks, right? If I were to, let me zoom in a little bit on, that's probably too far. I'm just going to zoom in on this part right here, right? And so you can see, right, we're at January 15, January 22. You see, well, the models only go forward 4 weeks. Why is that? Why don't the models go out further? Remember that little tidbit that I mentioned a few minutes ago about human nature and what human nature might do, right? It's really hard to predict human nature beyond 4 weeks, right? If cases are lower, we don't know what decisions individuals might make. We don't know what decisions public health or government entities might make. We don't know how people are going to gather together or not, right? We can make assumptions about those sorts of things. But beyond about 3 or 4 weeks, it's really hard to make an assumption, and our assumption is probably going to be wrong. So these models, these projections or forecasts rather, don't go out beyond 4 weeks. So let's talk a little bit about forecasting versus projection and what these things mean. So forecasting is based on the current data. I'm looking at the data that I have, the interventions that are in place, the epidemiological situations that are in place to understand what the next few weeks might be. Beyond that, I'm doing what are called projections, and that might be, we have a set of assumptions. We don't know what those assumptions are going to be like, but we're just going to take a stab at the dark and think, we've got maybe a few assumptions that we might look at. Future non-pharmaceutical interventions that might be in place, vaccination campaigns, emergence of new strains, right? All of these things are out in projections, and projections go out much further than the forecasts. As you might imagine, they also have much more uncertainty than those forecasts. So again, here is that graph that I just showed of incident weekly cases in the US. You can see it only goes out 4 weeks. Here is a projection of, a series of projections looking out much further than that. I do have time down here on the bottom, and you can see that these windows go out to like middle of March, right? And the projection started back in about December, right? So it's projecting out 3 months, 4 months in advance. Let me pause the slideshow and show you another tool that you might use to look at these scenarios. It's called the aptly named Scenario Modeling Hub. Let me just refresh the page. And so you can see here, we've got a number of scenarios that are in play here on the left. So the way that the Scenario Modeling Hub works is that they have a number of things that they might consider. They always get it down to 2 things to consider so that we have this nice 2x2 graph here. And so the 2 scenarios that they're thinking about here are optimistic versus pessimistic severity and high immune escape versus low immune escape. These scenarios were thought of back in December of 2021. So right as Omicron was kind of building up and we were starting to understand more about this new strain, the folks that run the Scenario Modeling Hub got together and said, all right, what are the things that are going to be most critical with Omicron? The amount of immune escape and the amount of severity. Those were the 2 things that won out. And so they then said to their teams of modelers, go forth and project. Go out 6 months and give us the number of cases, the number of hospitalizations, the number of deaths, and give us some confidence around those, right? Give us an interval of what that might look like. And so what you're seeing here is the ensemble on cases, incident cases, and what those cases might look like. And so you can see, the gray shaded area is what the ensemble thought would happen. The gray dots are what actually happened. And so you can see, the ensemble thought a little worse than what, the actual data happened. Again, all models are wrong. Some are useful. Where these ensembles for projection are useful is thinking about the long-term shape, right? What's the long-term shape or wave going to look like? And so in that regard, the ensemble of projections did quite well, right? Because it said there's going to be a peak at some point in the future. That peak is going to be much higher than where we've been in the past. We don't know how high, but it's going to be higher, and then it's going to level off, and then we think we're going to get back down to levels of COVID that we had seen prior to the Omicron spike. So generally, so far, at least, we're seeing that, right? So the shape of the curve here is intuitive. I'm going to switch to no uncertainty so that you can see the actual black line. And then I'm going to show all projections so you can see there's kind of a spaghetti plot of every individual projection and what might happen. And you can see there's quite a bit of disagreement, right? Some models, this light blue or this light green model, have the wave earlier. Some have them higher than others, right? This USC or the UVA model that I'm showing here. And then this pink model has it going out much further, right? That doesn't appear that that's going to be the case, but you can see there's some disagreement with the models themselves, and that disagreement changes even among the scenarios, right? So I would say, you know, as we've learned more about Omicron, we're probably in this either scenario B or scenario D scenario here, right? Where we've got a low amount of immune escape. And by low amount of immune escape, we mean you know, about 50% of previously immune are susceptible to infection. We don't think it's as high as 80%, but we do think it's a healthy number. And we also think that, you know, the severity, well, I'm not sure if it's a 70% reduction in severity, but it's probably more like a 30% reduction in severity, right? So scenario D here is probably the most likely one, the one that is probably most grounded in reality. That's not to say that A, B, and C are wrong. It's just that those were different assumptions that were made by the models at the time. So this is, again, the scenario modeling hub. You can use this to kind of get a sense of what might be going on, not only in the US, but again, in your region, right? So let me go to Maryland. I'll just be equitable here and try and get around to all the states. And you can see the ensemble here, right, had a peak. It forecast to peak a little higher and a little later, and now we're going down. If I were to spaghetti model that, you can kind of see the same thing. All right, going back to the slideshow here.
This is fascinating.
Thanks. I'm just noticing too that I had one comment in the chat from Tree from Fauquier County, and he mentions weather, more outside, more fresh air, less close or enclosed contact. We're actually going to talk about that about 2 minutes with the next thing that I'm going to mention. All right, so now that I've given you some tools to look at to assess cases and where cases might be and where cases might be going, now let's kind of flip this on its head and think about risk assessment, which I think is really why you're here. So we've spent 40 minutes talking, you know, math, stat, which is my profession, but now I'm going to switch hats. Key questions and concepts here for chapters to consider when they're thinking about risk assessment. You can see them listed here on the slide. What's the makeup of my chapter's activities? Is it rehearsals? Is it quartet events? Is it large-scale shows? Is it sing-outs? Are those things inside? Are they outside? Right? What does that look like? How often are we getting together? Right? All those sorts of things constitute the makeup of your chapter's activities. Who makes up your chapter's activities? And for that, you know, I would focus mostly on these two sub-bullets here: the health status of your members, as well as the vaccination and booster status of your members. Both of those things are key, right? We know, for instance, that COVID is more severe in the older population. It is more severe in the immunocompromised population, which also tends to skew older. And so think about your chapter when you're making these risk assessments, right? Is your chapter a chapter of younger and healthier folks? Or is your chapter older, immunocompromised, you know, diabetic, overweight, right? You don't need to know the health history of everybody in your chapter, but you should have enough knowledge of, like, oh yeah, Jim is 75 and, you know, he was in the hospital a few years ago for his diabetes and he's having to manage it. You know, like, know the general makeup of who is in your chapter to then assess risk appropriately. Key to that as well is the vaccination and booster status, right? We know that vaccinations and then again boosters really reduce you know, hospitalization rates and death rates. They don't necessarily reduce cases, but they do reduce the most severe outcomes for everybody in your population, including those that are immunocompromised, including those that are older. So consider that as well. Do you know the vaccination status of your chapter? Do you know the booster status of your chapter? The next question is a big one, and one that Alexandria grapples with every single time my committee meets. How much risk are we willing to tolerate? And what does that look like? As you can imagine, with me being a statistician, right, I'm thinking about that in terms of percentages. We'll talk a little bit more about what that might mean mathematically in just a little bit. That'll also, I think, answer one of Tree's questions about kind of outdoor versus indoor. So how much risk am I willing to tolerate? What does that look like? How does that risk change with the current COVID situation or with any preventative measures that I might put in place, those non-pharmaceutical interventions that I can put into place to reduce that risk, to reduce that R naught, and so thereby reducing the amount of risk of, an outbreak happening. Which interventions am I willing or not willing to tolerate? Is singing in masks okay? Is, a mandate of vaccinations in my chapter okay, or is it not okay? And what does that look like? And then finally, am I prepared for a virus outbreak scenario? In case something happens, and in case there is an outbreak at a show or an outbreak at a rehearsal, am I prepared to handle that outbreak scenario? Right? You want to ensure that the outbreak doesn't spiral and become something worse. And I would argue your chapter's reputation is probably on the line as well. That's something that Alexandria thinks about long and hard when we think about our risk assessment too, right? Not only what's the current situation, what are the measures that we might want to put in place or not put in place, how much risk are we willing to tolerate, but then also, what happens to our reputation if we have an outbreak at a show? What does that look like, right? Have we done everything that we could have done to ensure that we're okay? Or if it's not handled well, will that reflect poorly on us? Not only as barbershoppers, but us as individuals, or in my case, me as a professional, right? I'm very concerned about that. So, am I prepared to handle that, and what is the reputation hit that I'm willing to take, if something negative happens? So one thing that we do in Alexandria is really focus on tracking. In 2021, when my COVID committee was stood up, we sent out a questionnaire, and that questionnaire was a very simple one. It said, what's your name? Have you been vaccinated or not? What was the date of your vaccination? And then we asked for proof of that vaccination by setting up an email address where people could send their card, take an image of their vaccination card and send it to us. Or if people didn't feel comfortable with that, to just show us the card the first time that they showed up to rehearsal, to show proof that, yes, I was vaccinated on such and such a date with such and such a vaccine, and my card says so, right? So we track all of that, right? We track it by part, as you can see here. I'm blocking out names so that we don't have anything close to a HIPAA violation. But we track by part. We track by who is active. There's this ineligible category, which I'll get to in a little bit. We have vaccine, we have date, we have proof, and we have a waiver that we have asked our individuals to sign, essentially saying, if an outbreak happens, the chapter has taken all proper precautions, or as many precautions as we believe are reasonable, to prevent an outbreak from happening. And if an outbreak happens, it's unfortunate, but it happens. You're waiving responsibility essentially. We're also tracking boosters and the date of boosters. And then over here you can see state. And if I were to show my little tracking spreadsheet, which is this guy, and show this, which again does not have names, right? You can see I'm tracking by state and by county. Why am I tracking by state and by county? I'll get to that in a minute. But I track down to the county to determine, all right, where are these people? What does the virus look like in where they live? And then, how safe might it be for us as a result? Okay. More questions in chat. And it looks like Steve answered some of them. I can talk to some of that too, Tom from Sussex. I know that there have been 6 or 7 cases that have come from Midwinter. I know that BHS was putting out a survey to all Midwinter participants about that. to understand how many cases there might be. Okay, getting back here, and I'm just going to move this. All right, so risk assessment considerations, right? Again, we've talked about some of this already, but case hospitalization and death rates, tolerance, right? This is the big number, right? How many outbreaks per year am I willing to entertain? How many cases per year, per month am I willing to entertain in my chapter? Chapter and member health, vaccination status, testing and tracing capabilities, right? Is testing readily available in my area? Or as we saw with Omicron, is there a lack of testing? That may inform how you get together as a chapter, or if you get together as a chapter. Other things to consider: transmission in a singing environment, which we'll get to in just a second now. Governmental and public health guidelines and considerations, right? We don't want to go astray of anything that a government or a public health entity has issued. If there's a mask mandate in your area, you should follow that mask mandate. You should not break the law. And then finally, reputation, as we talked about already. This quote here from Dr. Fauci is key. You do not make the timeline. The virus makes the timeline. The virus will always surprise us, as we saw with Delta and as we saw with Omicron. You should be prepared for changes as a result of that. You should not have your plans be so ensconced or so firm that a change in the virus status, catches you flat-footed. Alexandria, in a notable example of this, had to cancel our fall show. We canceled our fall show about 3 weeks in advance of the show happening because the Delta outbreak started happening. And we went from rehearsing without masks in much of June and July to rehearsing with masks, to putting a cap on the number of people that could be in a room, to no rehearsals at all and canceling the show. So that's just one thing that we consider. Consider it as things move forward, right? Use those forecasts, use those scenarios to consider that. Okay, now a couple of risk assessment tools and a couple of things that I like to use. This tool from the folks at Georgia Tech is wonderful. It is called the COVID-19 risk map or something like that. I'll show it here in just a second. What it essentially does is it takes, sorry, let me move this down here and get to it and reconnect. So what this does is it takes case counts in every county in the United States or in Europe, actually, and it assigns a risk level to that to that county. So if I zoom in on our region here, you can see much of it is orange. Some places are red, some places are less orange than others. We have a risk level here in percent. What is this risk level? It is, as you can see here on the left, the estimated chance that at least one COVID-19 positive individual will be present at an event in a county given the size of an event. So there's a little toggle down here at the bottom where you can toggle the event size that you might have. So it's the default size is 50. You can't set it to individual numbers on the map, but you can do so on this real-time US and state level estimates tab, which I'll show in a minute. And you have our friend here, the ascertainment bias, right? You can see we have 3, 4, and 5. So how I would think about this, 3 is an ascertainment bias where the test positivity rate is low. 4 is an ascertainment bias where the test positivity rate is about where it is now, 10 to 20%. And 5 is an ascertainment bias that might be beyond 20%. And you can see as we go from 5, you can see the map is more red, 4, and the map is less red, but it's more orangish, and 3, the map is even less red and more of that light orange color, right? So depending on the ascertainment bias, the map here does a mathematical calculation of the probability that somebody is COVID positive. It depends not only on the rates in the individual counties, but then the ascertainment bias itself. So for instance, if I were to zoom in here, I'm just going to choose the District of Columbia. You can see the current risk level for a gathering of 50 people in the District of Columbia, given the current rates of COVID in our region, is 70%. So that is basing it on the current case rates and saying, all right, if there is, a 1% chance that somebody is COVID positive, that any one person is COVID positive in my region, then the opposite of that is 99%. And so what this map is doing is multiplying that 99% chance that somebody is not COVID 50 times for the number of people that are at my event. So 99% chance times the 99% chance times the 99% chance, right? You would think, all right, it's a 1 in 100 chance that somebody is COVID positive. Probably not going to happen to me, right? Well, if you multiply 99% enough times, you get to there's a 70% risk level or only a 30% chance that nobody will be COVID positive, right? So that's what this map is doing. And so the ascertainment bias and the case counts reflect that probability, right? The ascertainment bias is 4, all right, now it's a shade higher than 1%. So now I'm multiplying 98.8 times 98.8 times 98.8, right? And eventually I'm going to get to only a 20% risk with a 4 times ascertainment bias, right? Obviously the event size affects this, right? If my event size is only 20, I'm multiplying that 99% fewer times. And so as a result, I can, there's less risk associated with a smaller gathering, right? Here, there's only a 48% risk in the DC area of a gathering of 20 people. And that gathering, that risk kind of changes again with the COVID rates in the area. If I were to go all the way up to 1,000 people, if I were having a huge show or something in a packed auditorium, virtually guaranteed that somebody is going to have COVID in the auditorium, right? So that is this map. It is really cool. It's a really great kind of naive tool for understanding the amount of risk that is in your area. This map was great in 2020. Where it falls short is in 2021 when vaccination enters the picture, because this is just using case rates. It does not use vaccine status as a helper to that. So if I were to have, say, a gathering of 50 fully vaccinated individuals, well, this says I have an 80% risk of that happening. That number is probably lower than that, because we know that the vaccination, the rate of COVID among vaccinated persons rather, is lower, about 5 times lower than among unvaccinated persons. And the amount of vaccinated persons is about 80% of the population, about 20% of the population is unvaccinated. So use this as a naive and probably a high risk estimate for what is going to happen. If the ascertainment bias is 4, because the test positivity rate is 4, I would set it a little lower to kind of account for if I'm having a fully vaccinated gathering, right? So just something to consider. The next tool that I'm going to mention is the Jimenez aerosolization transmission model. Actually, first I'm going to pause and see if there are any questions. I'm not seeing any, and I know that I'm close on time. I've got this, and I think one other thing to showcase, and then we'll be good. Yeah, Miriam, Georgia Tech tool is probably a good upper bound. That's right. Yeah. All right, so this aerosolization risk model. Let me back out and show this, which is this. Okay, so there's a huge README here. Essentially, what this tool is a tool that helps out with thinking about indoor spread and what that might look like. So somebody asked earlier about indoor versus outdoor spread. We know that outdoor spread is lower to an extent, roughly 18 times lower than an indoor spread at a given event. This model will help estimate indoor spread and what that might look like. So this master choir tab is a very good tab to look at. And here, if you look at the orange inputs, you can input things like, how big is the room that I'm practicing in? How long is my event? How many times am I going to have an event? Is it a show or is it a set of rehearsals that I'm going to have over a given month, right? Things like that. Ventilation with outside air, right? These things might be beyond what you know, but they're good defaults to have at least at first. And if you happen to know these things, great. You can plug them in and you can help yourself out by knowing, kind of what the situation might be. So all of these inputs, total number of people present, fraction of population immune, right? That's probably about 60%, given what we know about vaccinations and so on and so forth, right? Use this tool, download it, put in, your scenario that might involve, all right, I'm having a fully vaccinated gathering. The gathering is this amount of time. It's this many people, right? And then you can play with all of these outputs, and this will give you conditional results for a given event. So if somebody is positive, what is the likelihood of infection if somebody is positive at my event? How many COVID cases might I expect? Number of hospitalizations, number of deaths, right? And then it also gives, okay, given the amount of virus that's spreading, what is the actual or absolute number, right? So probability of infection for a given person, number of COVID cases arising, hospitalizations, deaths as well, right? You can play with all these numbers to get a sense of what that looks like. Alexandria uses this as the basis for what our risk profile is. So if I go back to my tab, I've got another tab here that shows counties, our case rates in our region, the test positivity rate, the vaccination rate. And I use all of that to get an average of our case rates. And then I think about, all right, what's the exposure risk? What's the infection risk? And then these are kind of various scenarios that I've put in play. So I've got my own downloaded version of the aerosolization transmission model. I use that and I say, all right, we're only going to have a mask requirement. What does that look like? What's the probability of infection given that? All right, I've got a vaccination requirement. What's that look like, right? So these are probably way too many numbers for anybody to comprehend, right? But all of this is just to say, play with this aerosolization transmission model, have a number of scenarios that you might have in place in your chapter for what a rehearsal might look like, right? Is that rehearsal outdoors or is it indoors? Is it indoors masked or indoors not masked? The NFHS has recommendations that you should change rooms after a certain period of time. Can you do that? What does that look like, right? And so you can play with all of those sorts of kind of scenarios to build your own scenario and kind of assess risk if you wish, right? If you just go, Jason, all right, that's too much information. I don't want to do that, right? Go back to the Georgia Tech tool. The Georgia Tech tool is a good upper bound, right? Simple, easy to use. If you want to dive into the weeds, go with the aerosolization transmission model. It'll provide a more accurate number, okay? Last thing, and then I'll open it up for questions, and I know we're over time already. Have a plan in case of an outbreak. This is the flow chart that Alexandria uses. I know it's a little hard to see, but we have a flow chart here for if you're feeling sick, do not attend any harmonizer event. Contact us, right? Contact Terry Reynolds and the email address that we have set up, which feeds to me to know, hey, I've been exposed or I'm sick, and then go get a test. If that test is positive, isolate for a period of time, right? And then let us know, keep us posted. If that test is negative, monitor your symptoms, let us know, right? So all of these things are in place for us in case we have people that are showing up sick, people that have an outbreak. The biggest thing really is if you're sick, don't show up. Don't be a hero. I've been a hero way too many times, and I've probably caused too much illness than I care to admit, right? So don't be a hero. If people are sick, have them not show up and have that plan in place in case an outbreak might happen. Going back one more time to what I have here, I also have on my little spreadsheet here a tab for an exposure event, right? So we had an exposure event in October. We were asked to perform at a funeral for a chapter member's spouse. There was an exposure at that event. Somebody at that funeral tested positive. And so we told the chorus, all right, there's been a positive test as a result of this event. And we followed the protocols that were in place to say, okay, you need to get tested within 5 days. You should isolate yourself if you can, get tested, notify us of the results, or wait 2 weeks and have that be that. Fortunately, we only had one member that had a case as a result of that event, and that was a direct exposure to the initial case. So we don't think it had anything to do with the course, thankfully. But have this prepared, right? Have a plan in place so that if an exposure event happens, you're ready to go, and you can capture all of this information and know who is okay. Okay, so people are asking about URLs. That is my last slide. Here is everything that we have shown so far. So the US COVID Risk and Night Vaccine Tracker, the Hopkins, the Times, and the CDC. These are all maps to get a sense of what are things like in my region. How bad is it? And then the Georgia Tech Event Risk Assessment Planning Tool is this link here. The CDC Forecasting Hub, which we mentioned, is here. The Scenario Modeling Hub that goes further out is here. And that Airborne Transmission Estimator, if you want to get really scientific and in the weeds, is at this URL here. With that, that is everything I have. I know we're over time, but I'm happy to answer any questions that you all might have.
Anybody have any questions at all?
This is Doug Brown. Jason, thank you so much for that. I really appreciate the in-depth look that you did. One thing that I haven't been able to get my arms wrapped around, and that's any group that is highly vaccinated with masks, whether they're N95 masks or something beyond just, single layer cloth. What I haven't been able to understand is how often are people kind of getting reinfected by COVID, or is it literally that you can get the Delta and you can get the original and you can get the Delta and you can get the Omicron? But if you've had Delta, you're probably not getting Delta twice. If you've had Omicron, you're not getting Omicron twice. But I'm really trying to get, we had a group of friends of ours from the chorus. I mean, when they tested, they isolated and all this kind of stuff. But my question is, to what degree are they likely to get it a second time, number one? And Jeff had also put a question in the chat. What's the likelihood that they could carry that virus if somebody's had COVID recently? Can they be a carrier of COVID virus to people that have not yet had it?
Okay, so I'll answer the second question first. These are both great questions. Thank you for them. To answer the second question first, yes, you can carry. The latency period, even if you've been reinfected, you can still infect others, and that latency period is probably roughly 5 days, right? It can be as high as 10 in some cases, which is why you've seen the CDC come out and say, isolate yourself for 5 days. 10 if you've been symptomatic, or if you've been asymptomatic, wear a mask for an additional 5 days, right? That is kind of the maximum amount of time that we would expect somebody to carry this virus forward. And that latency period that we talked about is roughly 5 days. So a generation of one person passing it to the next generation of people, that roughly takes about 5 days. So hopefully that answers your second question. The first
That's
question.
my second question, by the way. I was the author of the second question. And does that, if you were vaxxed or boosted or whatever, are you less transmissible to somebody that isn't? Or is it's just aerosol and everyone's got an equal shot?
Yeah, good question. We believe, at least the scientific research that I have seen, tends to say that if people are symptomatic, they are exhaling the same amount of virus regardless of
their
vaccination status or booster
Right.
status. That is really, though, dependent quite a bit on symptomology, right? The thinking is that folks that are asymptomatic may have lower viral counts and so then may spread less. But that varies from person to person, right? One of the theories, actually, to get just a little tinfoil hat and a little conspiracy theory, one of the theories on how Omicron came to be is that it was one person that was immunocompromised and had the virus mutate in their system for a very long period of time. And then finally enough was built up that they were able to spread it to somebody else. So, that sort of thing can and does happen. And it's all dependent, at least to some extent, on your health status and then your symptomology. Doug, to answer your first question about reinfection, yeah, reinfection can happen. The general thinking is that people are not reinfected for about 90 days. That you tend to have pretty good immunity if you've been infected for about 3 months, and then your immunity begins to wane. We've seen that both with natural immunity as well as vaccinated vaccination immunity, right? Those antibodies begin to wane 3 to 5 months, right? Part of the reason why the booster is out and is available, and part of the reason why they say wait 5 months. It's also part of the reason why it's said, if you've had a previous shot or if you've had COVID, you should wait, to get any sort of vaccination series, any additional vaccination. So, yeah, you can get reinfected. Sometimes it'll be the same strain. Oftentimes, though, because of that amount of time that passes, it'd be pretty rare to get reinfected with Omicron again. But it is possible, just because of that waning immunity.
Jason, thanks. One clarification. If I've heard people that test positive, even though they have no symptoms, no
Yes.
outward symptoms to speak of.
Yes.
If somebody has no outward symptoms, then we really would have to be concerned about who else that they could be spreading the virus to, because they wouldn't even be able to know that they had it. So I'm just trying to reconcile your comment about when somebody is symptomatic. Yeah, then they're probably much more of a carrier than if they're asymptomatic. I just don't know kind of order of magnitude, if you even can hazard a guess in terms of what that might be for us, and advise chapters and run events.
Yeah, unfortunately, I don't have a good sense of viral load for asymptomatic versus symptomatic people. Other than that, the general thinking is that the viral load for asymptomatic persons is less, which I think in virology probably makes a ton of sense. George Korch can probably speak to this at length, and I cannot. But if there's less virus in your system, your immune system is more likely to handle it. What that means for you, though, in terms of who should come back after a positive test or something like that, we tend to follow CDC guidance quite a bit. CDC guidance has taken certainly its lumps, but it's my belief that it is founded in the science, and the science there is, if you've tested positive, wait 10 days, and after that 10 days are over, yeah, you might still test positive because you might have lingering amounts of virus in your system, but at that point, your immune system has beaten back the virus, and you're not likely to spread at all after that point.
Thank you, Jason.
I don't have a specific article to point to, unfortunately, but if I find one, I will forward it along.
Okay, anyone else? Jason, this was fantastic material. Thank you so much. It was fascinating to me. I hope that chapters can use this as they, contemplate getting back together, how they do so safely, how they take, care and precautions, contact tracing, accountability, that sort of thing. So thank you so much. I really appreciate you.
Of course, yeah. One last thing before I go, I've advised and consented for both the district as well as a few other chapters. So if you have further questions, if you want to reach out, please feel free to reach out. Rob could provide my contact information.